Australian situation well. I do know that, as is not rare for public policy, there have been some perverse outcomes from some of the aged care recommendations with what has been portrayed to me at least as an overly burdensome regulatory process. So it's good not to use antipsychotics as a general proposition. On the other hand, if you have people who require an antipsychotic because they have psychoses, having to fill out a form every 10 minutes to say that they're still psychotic is not going to help anyone, and it's going to have people shy away to use other meds that aren't as good as the antipsychotics, but will equally be sedating. So um, the dilemma we have in healthcare policy is we hate to say that something bad has happened, whereas scientifically, what we should be doing is searching for the perverse outcomes. And presumably, this was an anticipatable one that could have been sought out. So I think if we had a process that was focused more on error elimination in what we do, as opposed to everything being perfect all the time, we'd find that we would have a better stance in which to adapt to the maladaptations for the changes that we're trying to make. That would be my general sense of things. And by the way, I've seen that as some of the work that we've tried to do as well. But we're trying to be out in front of what the problems are. My general feeling about this is if we're doing something that's wrong, I, as the person, I'm not in charge. I'm what's called the senior medical director of the Frailty and Elder Care Network, which means I'm middle management. So both sides can shout at me, and they do. But if there's something that we've done, always with a bad heart, that has given us a bad outcome, I want to be the person who hears about that first. I don't want that to be hidden information that everybody else knows. So that's my general sense of how things are, and the way that inevitably there will be perverse outcomes or unanticipated bad results. Try and anticipate them, and then search for them if you can anticipate them. I see a very important role for AI because frailty is formally complex, and it behaves mathematically as a complex system does, and it behaves mathematically as complex systems do when they get close to failure. So to the extent that AI helps us cut through some of the verbiage around all of that and process data more readily, then I'm all in favor of it. On the other hand, unsupervised AI has its own risks of perverse outcomes. There's a thing called the early warning paradox. So if we look at measures that have been used for a long time to identify who's most at risk for an adverse outcome, we, with AI, more or less incorporate all of that plus biases. So for example, if we looked at the things that would put someone at risk to wind up in the intensive care unit and then to wind up in the intensive care unit and die, we would find that age is an important one, but it's not fixable, at least not till now. So it's not that important, although people want to risk stratify. So they say, well, over the age 65, and so and so. And generally what they mean is frailty, but they don't know how to specify it. Mm. We would also find, though, oddly, that anemia is not that important. And is because it's not very important? No, it's crucial. If someone's got a hemoglobin of 37 and that's new, then we have to act on that with elegant quickness. But because we generally do and we generally succeed at it, people don't die from it. So it doesn't show up in the warning algorithm because the AI is just an algorithm that can't make sense of anything. So we just look at all the things that resulted in a bad outcome and stuff them to the extent they can into an algorithm to come up with a score, which if it's a black box score, we won't know what the driver of that algorithm is. So we need to be very cautious about that. We need to be very careful. And as before, we have to be alert to adverse outcomes, or we have to be alert to unintended consequences. And so knowing that they're looking for them, I think is the sort of thing that we want to do. We need to be skeptical, scientific, not implacably so. We have to be able to be satisfied, but we need to approach this with a certain degree of caution. I've found that the merit of the Frailty Index is it's helpful as a screening tool. So, and it tells you both not that someone is frail versus not frail, it tells you how frail they are. So if there was something that would enhance the Frailty Index more, then I'm 100% on board with that. But I need to know what it is. I think we have to be able to understand what is driving the alerting process. And again, we have to realize that the Frailty Index is meant to be a screening tool. And then if it gets used afterwards, um, after an assessment has been done, so you screen to assess, right? So if it's being done after an assessment has been done, then I think it could help us by saying things like, if you have someone who's got a frailty index score that would go with being, say, moderately frail on the clinical frailty scale, then we should be aware that this is a real important test for the hospital. We know from some data from various parts of the world, but including Australia through the Australian New Zealand Intensive Care Society's work, which has been fantastic, by the way, on defining degrees of frailty. We know that there are some places where moderately frail people have a much higher risk of death and institutionalization than other places, and it varies by hospital. So it becomes a focus for inquiry. Why is that? What are the factors associated with it, and so on. So it should help us ask better questions and ask them more precisely. Someone who wants to do research on frailty, good on you. That's wise of you and far-sighted, and you're tackling a problem that's really important from a societal standpoint, and you should be rewarded for that, as opposed to people who've fallen into a particular supervisor's research program where small differences, they're important, but they're not as important as understanding one of the major challenges to contemporary healthcare, which is how in a system that has largely succeeded by getting ever more subspecialized, how do we deal with people who have that subspecialized thing wrong and a bunch of other things too? And so if you're doing that work, fantastic. The mistake in my experience that early investigators make in this field and others is what I call the premature specification of their model. So let me take an example dear to my heart. Unfortunately, researchers of my generation prematurely specified the model of what successful Alzheimer's disease treatment looked like. We thought that because people have memory problems as a key function, key feature of Alzheimer's disease, that if we treated them, their memory should get better. And in some small fraction of patients, it does. But the more reliable treatment effect that we see is people's executive function improves. Now, the dilemma with that is executive function has been a very tricky concept to operationalize, and we've all been, for better or for worse, we've all been subject to the paradigm that the psychometrists use, where they specify everything as a pick your test, and they put huge emphasis on the reliability of the test. And they assume the validity will take care of itself after a certain basic amount of work has been done. And what we find with executive function is that most of the tests we have of executive function are nowhere near as good as a clinical discussion, as talking to a patient. And we also have come to realize, or hopefully have come to realize, that it's not bad to have a bad memory if your judgment is good. It's not bad to have a bad memory if your planning is good. You can plan to have an alert come and flash in your face and tell you now's the time you're supposed to be at the next interview, by the way. If you can inhibit your base desires, if you can get engaged in something, have the initiative to get going and the stick-to-itiveness to stick to it, all those are the things that when they start to erode, that's what makes dementia dementia. It's not that you're forgetting about the thing you're meant to do, it's you don't care anymore, or you can't imagine the future with you in it as someone who has agency. And for many patients, the main effect of a cholinesterase inhibitor is to improve those things. So if you're walking around saying, I've treated these patients, the man and boy, and I've never seen anyone get better, you haven't been paying attention. You have not, I 100% guarantee you, you've not been paying attention specifically to the fraction of patients whom their executive function is better. So when an adult offspring of a person with dementia tells you, my dad is back now, he or she is zeroing in on something that's really important. And typically what they're zeroing in on is my dad is conforming to him living life the way he's been always used to living life, and that is to an end, to an objective, to a thing. And so the chances are that if dad had lost his ability, because now it's back, if he'd lost the ability to conduct himself with some sense of the purpose in his life, and he gets it back, that's a remarkably important treatment effect. And the fact that we aren't good at measuring except by talking to patients means we should put a little more effort into how we talk to patients. And said, you haven't, he used the term master, but he meant you haven't really understood deeply an area until you've learned its hard teachings. So everything I'm going to tell you next is hard teachings. So one thing is that you may be leading a team, but you don't have all the answers. What the team is looking to you for is some sort of vision, some sort of general sense of the plan. Where are we going? Why are we trying to get there? Something that is the motivation for the inquiries. You should be good at that. But at the same time, how you get there, you may not have every answer to that. And if someone has put enough effort and thought into it to give you a serious proposition, and if they're a junior person, they put a lot into this, and it is nerve-wracking for them. They've been up thinking about it and such. Show them the courtesy of listening carefully to what they have to say, and don't dismiss them up front. So your gut reaction may be helpful, but Daniel Cannon, type 1, type 2 thinking and such, be prepared to give something the merit that it should be allowed. So that, I think, is the most important thing. The corollary of that, now I'm going to quote Aristotle. It's never good when I start quoting people, but one of the things that Aristotle said, this is in the Nicomachean Ethics, by the way, if you want to go look it up. He said, it is a mark of a man, again, he meant person. It's a mark of a person's education and their general outlook, that they bring no more precision to a question than the subject matter allows. And so we see sometimes people becoming hugely precise about things that they don't need that level of precision to make a valid conclusion about. So a moment ago, I spoke about premature specification of the model. People then get way too precise in figuring out exactly which aspect of memory is better, and not stepping back and saying, the memory isn't the big thing here. Let's try and think more carefully about what the big thing is. That's the second thing. The third thing is, don't hire a bunch of people who all think in the same way. Don't hire a bunch of people because they seem to get along with each other. You need to hire people who are going to help the team do a particular aspect of its job. As long as they are not being disruptively objectionable, it's fine if they don't get along. It's fine if they don't want to go out and hang out with each other at night and all those sorts of things. You need to have a team of diverse talents. And you, as the person who is in charge of it, have to be open to each person in a way that's meaningful for them, right? So it's not that you're being a chameleon, but all of us have many facets. And if you can make a relationship work with someone on a facet that is not particularly that important to you, but important enough for you to want to engage in and such, do it. If that's the thing that person cares the most about, have some courtesy and try and help them have that conversation, have that moment of connection with them. I learned this when my great friend and colleague Arnold Mitninsky died. And if you know our work at all, you've seen Rockwood and Mitninsky and Rockwood dozens of times. But after he died, and I wrote a eulogy for him. It's published in Biogerontology if you want to read it, because he was a remarkable guy. Anyway, people came up to me afterwards and started to talk to me about the relationship they had with Arnold. And I have a colleague who's just a fantastic musician, and she and Arnold talked about music, because Arnold had a deeply structured understanding of music. His daughter was a classical pianist, actually. He knew about it well. Someone else who I didn't know was into poetry came up and talked to Arnold about poetry. And Arnold could quote various of the Russian poets, uh, Nabokov being one of his favorites, and have a deep understanding of that. But I was a good friend of Arnold's, and I knew little slices of this, but I didn't realize the whole person and how deeply into everything he was. And so Arnold had that genius to connect deeply with people, even though he's a private person. He maintained his privacy by showing most people just one aspect of his character. So, in the same way, be prepared to explore the many facets of yourself as a leader. And also, there, there is nothing wrong with being wrong. There's the wrongness is when you're wrong and obstinate. So a good leader has humility. A good leader, in a fundamental way that you can't fake, sees himself or herself as the servant of the team, as the person who's trying to figure things out for the team. There's ways to go too far with this. There are things that are tough. I remember at one point when before we were very well established, I had about 20 people working for me, and at times it felt like I had 14 or 15 mortgages to worry about, because if we couldn't get the grant, it was all going to fall apart. And so you can only take so much of those things on. Try and stick with the problems that you can actually solve. And then the final thing I'd say is find a good mentor. Often these are organic relationships that just spring up. But if you've got someone whose advice you value, don't bring them trivia, but don't keep from them things that are keeping you up at night. Go have a talk with them and see how they can't help you with that. I think those are the really most important things about starting a research career or any other, I'd bet. I am subject to the sin of pride, being a man of a certain era and with some ambitions. So personally, I myself never call it the Rockwood Frailty Index or Rockwood Frailty Scale. Clinical Frailty Scale, Frailty Index is good enough for me. But what I'm really happy about is, particularly with the Frailty Index, opening up a phenomenon that can be studied. People have done PhDs on how the Frailty Index behaves in a particular environment. So, in other words, what its distribution is like, how it shapes and changes, and such. And if you look at some of the work that we published around 2001 to about 2008, a lot of it was concerned about things like that, and that has now, a lot of stuff we figured out at that time was true. Not everything was, obviously, but it allowed the Frailty Index to be understood as a way to approach what otherwise is, if you're trying to look at every part one thing at a time, you won't get there. But if you get a sense of the ability to integrate it. And so in that sense, the clinical frailty scale coming out of that work, it was the other way on, right? We developed the clinical frailty scale in the mid-90s, and when I look back at the work now, I can see how we're slowly getting to the frailty index. But in the end, the clinical frailty scale, when it's summarizing the components of a geriatric assessment into an overall number, but a description that gives you insight into what the care plan is, particularly when someone's acutely ill, I think I'm glad to be associated with that. The idea, of course, is that what we're trying to do with the care plan is we're trying to make someone better. That's why they come to the hospital, right? So I'm speaking from an acute hospital standpoint. They come to the hospital. Why is that? Because they're sick? Well, not just because they're sick, because they hope to get better. And for most people, the amount of entropy that we can overcome in a reasonable period of time is to try and get them back to or on the road to where they were 2 weeks before they got sick. So when someone's frail to start with and they're acutely ill, particularly if they have any degree of severity of the acute illness, knowing where it is you're going is really important, and knowing if you're going to get there. And shockingly, so many patients come to the hospital and no one has any idea what their baseline is, and no one has any idea about what their aspirations are, and no one has any idea about, because they're frail, they're often depending on someone, how that person on whom they're depending feels about this grand plan that we've got for them to get back to this state, if that state was even the right one for them. So when it's used properly to facilitate a geriatric assessment, I'm really happy to have been involved with that. I became a geriatrician with the final bit of training done. I was pronounced full of ideas. No new ideas could be taught to me by certification of the Royal College of Physicians of Canada in 1991. And when I started first, I had much more hair than I do now, and I wore it in a ponytail. Before that was entirely fashionable. Um, and I was a call me Ken geriatrician. And in 1994, my dad got really sick, and he was in hospital, and I was trying to advocate for him. And I remember really well interviewing, um, speaking with a colleague, a cardiologist who was helping to look after dad, and the disgust in his eyes when he talked about my father, who at that point was quite disabled and confused, delirious. And when he looked at me, I'll never forget. And that all happened on a Wednesday. And on the Friday, I went out and got a haircut, and I bought 2 suits. And every day of my professional life up until the Panda, well, actually the year before the Panda, every day I wore a suit to work, including when I worked in the emergency department. Just before the pandemic came on, um, it, I've been thrown up on one too many times, and so I started to wear a scrub shirt and jeans, and then during the pandemic, only scrubs. And now I've gone back to mostly at work when I'm seeing patients. Scrub shirt and jeans is fine from my standpoint. So for a while, though, I was very alert to how my presence would be interpreted, not by my patients as much. I think I've been blessed with being able to talk to people, but certainly how I would be perceived by my peers. And so I paid careful attention to that and became a little less fringy than I was apparently appearing, although in here, still in the fringe.